Dear Chairman, dear colleagues, first of all, I have to thank the organizing committee and Dr. Spargas for this kind invitation. And in the next 10 minutes, we will discuss about when and how to perform transcatheter ASD and PFO closure. So what is a PFO? PFO is a persistent communication between the right and the left atrium. And of course, this communication is vital in fetal life, but after birth and as the lungs start to expand, we expect an increase of the pressure in the left atrium and the fusion of the primum and the secundum. But this is not going to happen in about 25 to 30% of adults. PFO is considered harmless in most people, and as you can understand, it's a completely different situation with the ASD. In the ASD, we have a hole, we have a defect, and of course, this is more infrequent, but it can create a continuous shunting between the left and the right atrium, and at the end of the day, volume overload of the right heart. So why we discuss about closing a PFO since it is harmless? Because under some conditions there might be a paradoxical embolism and material from the venous can travel through the PFO to the systemic circulation and embolize. And of course, this picture is something that none of us is going to face most probably in our career, but it shows that the thrombus can travel through the PFO, even from the more skeptical. And speaking about strokes, almost 40% of the strokes are cryptogenic, meaning that we don't have a clear cause of the stroke. 12% of the population with cryptogenic stroke might have a PFO, and excluding the relative older patients, it terms that 4% of these cases, the PFO might have a causal role. So our job is to try to find and go from this 38% to find this 4% of the patients. So our job is to find the strokes that are related to the PFO. And what we need, of course, we need a stroke, we need the neurological symptomatology, we need imaging, we prefer MRI, and of course, we have to exclude other causes, more common causes of stroke. The risk profile of this population is a relative young patients with no common risk factors. We need to exclude the carotid disease, and last but not least, we have to exclude atrial fibrillation. And this is very important because quite often we have referrals from colleagues who said we put a 24-hour Holter and we exclude AF. But this seems to be not the case. We need to be more precise. As we know from Crystal AF, in this study they studied population with cryptogenic stroke, and they implanted ILR, and almost in 9% of this population, they managed to detect AF at 6 months, and almost in 13% at 12 months. So we have to be more precise in excluding AF. As you can understand, patient selection is quite tricky and challenging. There are tools like the ROPE score we can use. In our institution, a ROPE score above 7 is mandatory prior to proceed with closure of the PFO. And again, we need the neurologists, the stroke physicians by our sides. Usually, these are the referral doctors. A cortical infarct is the rule. This is the embolic stroke and not the lacular infarct. And at the end of the day, the decision is in a level of multidisciplinary discussion in order to find the proper patient. Since we agreed that we have a patient who might have a causal role of the PFO, we need to decide how we will treat him. And the last 2 decades, there are a big discussion and a big evolution, and especially with a longer follow-up from the reduce, close, and respect trials, we now know that percutaneous closure of the PFO is superior than the antiplatelet therapy in terms of reducing the risk stroke in this group of patients. And this is reflecting in the guidelines of the major cardiovascular societies. So in the workflow of the selection of the patient, apart from the clinical characteristics that we discussed earlier, we have to take under consideration and some special characteristics of the PFO itself. There are some PFOs that are considered in high risk, the large PFOs, the PFOs associated with large tunnels or with aneurysm of the septum. If there is a presence of a Eustachian valve and carry network, or if there is a PFO that is always open and doesn't need a Valsalva maneuver. The size of the PFO, we can judge it with a bubble test. And over here, we have the other two major risk characteristics. This is the PFO with a large tunnel, and this is a PFO with an aneurysm. The procedure itself is not very challenging, let's be honest. It's quite easy to cross the PFO with a 0.35 wire and put a multi-purpose and over a stiffer wire to close the PFO. This can be done in a completely minimalistic way without any guidance in less than 15 minutes. But is this what we want from this group of patients? Probably not. Again, these are patients relatively young, 35, 40 years old, and our responsibility is to offer a program with, if possible, with zero complication risk and low recurrent event rate. Adding in our everyday practice the ultrasound guided puncture of the femoral vein and use of pre-close devices can minimize the risk of bleeding. And of course, the guidance of the procedure is better to be done under TOE or ICE, depending on the expertise of each center. There are many devices in the market. We will not go in details, but at the end of the day, the so-called simple PFO can be closed with a 25mm device. Larger PFOs associated with longer tunnels or aneurysm might need larger devices, and probably the balloon inflation in this case is beneficial. As in this case, this is the case I showed you earlier with a large tunnel. We use a 25mm balloon inflating up to the level when there is no flow anymore in the TOE. We measure the waist both in fluoroscopy and TOE, and in this case it was 12mm, so we have chosen a 30mm Figula 2 device to close this PFO. After the procedure, the patient should be stayed in dual antiplatelet therapy for 3 to 6 months and lifelong on aspirin. And we have, of course, to follow up the patient with bubble test in 6 months to 12 months to assess the effective or complete closure. And of course, a brief comment about the post-procedure AF. This is a nice slide from the work of Professor Choufis and that's showing and summarize actually all the details. The AF post-procedure is not very common, 5%. Usually it's observed the first month and then it goes down, and probably because of local irritation or inflammation. And let's finish with ASD. The most common is the defect of the secundum, the ostium secundum. Over here, the decision to treat is more clear. If there is a paradoxical embolism, we have to proceed with closure. If not, we have to evaluate if there is RV volume overload and pulmonary hypertension with less than 2 hoods and more than 2 hoods and less than 5. Which ASD is suitable for percutaneous closure? Usually the PFO that is less than 38mm, and we need sufficient rim, at least 5mm apart except from the aortic side. Over here we have more devices. devices that can be used in multiple fenestrations. But again, the procedure more or less should follow the same steps. Over here, the balloon is mandatory to size the defect and help with the correct size of the device. In conclusion, these both procedures require a careful patient selection. We have to be able to offer a safe procedure, especially in the patients with the PFO closure, and the final selection of the patient should be done in a multidisciplinary approach. Thank you very much.
Thank you very much, Dr. Mitsis. Our last speaker is Dr. Asvestas.